Okay, so we're going to spend the next, I think, I don't know, Jillian, 20, 25 minutes in a bit of a, sorry? Until 12:30, okay. In the question and answer session, I would like to invite the speakers from this morning to come on up to the table. I see Dr. Mente and Dr. Imran. And Dr. Turco. Okay, so we'll just spend a minute collecting the speakers, just like I collected some questions. I've tried to strategically orient the questions to cover all the range of excellent ones. There's some that we won't get to, some that I chose to defer perhaps this afternoon, so please don't be offended. And amazingly, I could read everybody's writing, especially with the reading glasses. So maybe we can start while a couple of the other speakers are collecting. First question to Dr. Mente. How likely are pathologists in non-teaching hospitals to diagnose NETs? And is there a network for consultation with pathologists across Canada?
So the first question is, the endocrine pathology is a subspecialization, so I consider that this case should be addressed to endocrine pathologists, but there are not many endocrine pathologists in the world as well, in North America and even in Europe. So, and the question is, we are getting a lot of consultation from our colleagues, from our pathologists, in some tough cases that they need our help. And there is not a network for the consultation for this one, but personal consultations and patients' requests are always welcome to our centers. But I can't say there is a real well-developed network for neuroendocrine tumor for consultations.
What about the States, Larry? Can you comment on that?
There are a group of pathologists that participated in writing the pathology guidelines under the auspices of the North American Neuroendocrine Tumor Society, and that's been published in the journal Pancreas, and any one of those co-authors is more than willing to provide second opinions.
Great.
And in addition to that one, there is a recent paper in 2009 that's defined clearly the minimum requirement for pathology reporting. And in addition to that one, we do have some College of American Pathologists checklist for neuroendocrine tumor that we have to provide in our report, the synoptic, which means the most comprehensive part of the biological markers and staging system. So the problem is here, if you need to assess some other prognostic marker, they are not available in most of the community hospital, but in a well-organized centers such as our center and the big pathology departments, we can deal with this one.
Great. Next question is for Dr. Topkot, and I'll just read it verbatim. Based on your presentation, there may be an obvious advantage in using PET scans as opposed to other scans. Should those of us who've never been tested with PET go and seek one?
Of course. I actually, all the data available about the sensitivity accuracy of PET scanners with the gallium-68 DOTA peptides is very more sensitive and more accurate in staging. So it's possible to somebody having like a local disease from the ocular scan to be, of course, a metastatic disease.
Could you comment on the importance of the differentiation and what test you might select for what kind of disease?
For the kind of disease, I think actually that the ocular scan with indium-111 is the first primary exam to perform because it's really available, but there is some problem to provinces to get funding for that kind of tracer. But I still believe it should be used first. And then if it's negative, and we will want really to be sure it's negative for the staging, the gallium-68 may be the second step.
Great, thanks. Dr. Coles?
You mentioned differentiation, and I think you alluded to this in your talk. The patients with grade 1 and grade 2, also called well-differentiated or moderately differentiated, are likely to have a positive octreotide scan in the 80 to 90% range. Those with poorly differentiated tumors are unlikely to have a positive octreotide scan because as these tumors have become more malignant in nature, more dedifferentiated, they don't act like normal neuroendocrine cells, and they lose the expression of somatostatin receptors, so they're going to have a negative octreotide scan. On the other hand, their aggressive growth behavior makes them more likely to have a positive PET scan with FDG.
You're right.
Excellent. Thank you very much. Next question, Dr. Coles. Isn't Sutent also a treatment option for pancreatic NETs?
Is what a treatment option?
Sunitinib. Sunitinib or Sutent.
Sutent.
Yeah, for pancreatic PNETs.
It certainly is, and it was very interesting. I don't know when this has happened, but when we were at the FDA recently, and I went as a consultant for Novartis, we had 4 hours to present data on Afinitor in the morning, and then they took their vote, and in the afternoon, Pfizer had 4 hours with the FDA to present the data on Sutent. And actually, Sutent, the paper, the landmark paper for Sutent was published in the same journal, same issue of New England Journal of Medicine, the same week, back to back, that Afinitor was published. And the FDA voted in the afternoon 8-2, not 10-0 as in Afinitor. 8-2 to approve Sutent. So it's also going to become an option for any of you who have pancreatic neuroendocrine tumors. There's a difference in safety profile. The percent of patients who have objective tumor regression is low, but similar in both. And time will tell in which order they're used.
Great. Next question is, and the questions for Dr. Imran will be saving them. I think he's on his bike. I don't think he could resist the sunshine. So don't worry, I'll get him Monday at work. I promise. Dr. Turcotte, what is the cost to send someone for dodeoxyritate therapy overseas versus, or basically what is the cost and logistics, if you could?
Okay, actually I haven't looked really about the cost because for about the tracer, it's not very expensive, so it may be about $500 to have access to the tracer. So it's not very expensive for the gallium-68 things. But when we'll like to do some treatment, so we have to import lutetium. So now it's flight transportation and approval in Canadian ground. And I'm supposed to receive in a few days a quotation on how to bring 100 millicuries of lutetium in Canada. So I will be more able to give you the final answer in a few days.
Okay.
But we are talking about $1,000 for the treatment. So that's less expensive than going overseas that may cost $20,000-$35,000. Some people need to mortgage their house for having a treatment overseas. So I don't want to recreate that in Canada.
So the overseas treatment is much more costly than...
Oh yeah, that's much more costly.
Okay, this is a combined question for Dr. Mehta and Dr. Turcotte. How do pathology and nuclear medicine work together to diagnose patients? And is there a relationship between the two specialties?
Of course.
Definitely.
Don't really need any more comments.
I would say this is a teamwork. We need surgeons, endocrinologists, medical oncologists, radiologists, nuclear medicine, and pathologists working all together. So there's not such a thing that I can work alone. So everything has the content in terms of teamwork.
Okay. Question for Dr. Coles. How do you test, or when and who should you decide to increase the dose of long-acting octreotide? You can reiterate.
I base the decision to change the dose of octreotide on two factors. One, whether or not I think I'm achieving optimum control of the carcinoid syndrome, or whether or not the 5-HIAA is increasing, and whether or not there is progression of the underlying tumor. So it's based on several factors. Is the tumor growing? Are the biochemical parameters increasing? And are symptoms poorly controlled? We know that as the metabolite of serotonin increases, if the normal range is up to 6, we know that when it gets above 50 to 75 milligrams per 24 hours, that the likelihood of developing thickening of the cardiac valves begins to increase logarithmically. When it gets up to 200, 300, the incidence of carcinoid heart disease can approach 50% or more. So even if the symptoms of flushing and diarrhea are well controlled, excuse me, I'm going to pay attention to that metabolite of serotonin because I want to prevent carcinoid heart disease. For the other situation, if there's progression of disease, even if the markers aren't going up, I will increase the dose to enhance the anti-proliferative effect. And finally, if there is, patients had well-controlled syndrome for 2.5, 3 years, but now they're starting to have breakthrough symptoms all month or breakthrough symptoms, before the next shot, I'll either increase the frequency or increase the amount.
Dr. Turcotte, are patients with allergies to CT contrast eligible for PET scans?
Mainly for PET scan, I'm talking about Quebec. We are not giving any IV contrast for doing the exam. The contrast is the radioactive tracer we are using, so there is no need for that. So no contraindication.
The other thing that can be done in that situation is an MRI with EOVIST.
Dr. Mehti, how long after the tumor is out of the body can one still accurately assess Ki-67?
Oh.
Can one go back and do it?
Yeah, sure. So let's say as long as we do have the paraffin blocks in our archives, we can try to make any assessment, any pathological assessment by using immunohistochemistry, DNA-based molecular tests. So there's not such a limitation. But the most important thing is we should have a well-preserved, well-fixed tissue and stored accurately in our archives.
Okay. Dr. Coles, do you ever, or what conditions do you add other medicines to control diarrhea on top of octreotides, such as pancreatic enzymes or other type of therapies?
Very relevant question. Many patients with newly diagnosed carcinoid syndrome will have malabsorption of fat, in part because of the rapid transit time. When we slow that down, the absorption of fat may improve. But then we have the double-edged sword. Sandostatin therapy itself, in some cases, will induce suppression of enzyme production by the pancreas. There's pancreatic endocrine function and pancreatic exocrine function. The exocrine function is the function that leads the pancreas to produce enzymes that help break down food. And when you suppress the production of lipase, fat doesn't get absorbed well, and unfortunately sandostatin may do that. So a question I ask my patients is, do your stools float? Are there oil droplets in the toilet bowl? Do you sometimes have to flush the toilet twice in order to get rid of the oily droplets? And if they respond yes to any of those, then it may mean that they are experiencing fat malabsorption because of a side effect of sandostatin. We actually measured stool fat when I was at the Mayo Clinic. Had patients collect their stools for 72 hours, and then a technician measured how much fat was in the stools. And ordinarily, we should absorb 95% of the fat in our diet. And some of these patients were only absorbing half or even a third. And in that situation, pancreatic enzymes can be very, very helpful. Now, understand that the commercially available enzymes are broken down by the acid in the stomach, so they have to be given along with something that reduces stomach acid, like omeprazole. So pancreatic enzymes can have a very important role to play, but they must be given with a proton pump inhibitor.
Great. Dr. Tilcott, can you elucidate again the specific criteria that makes a candidate suitable for PRRT, and are there any contraindications for suitable candidates?
Okay. For the indication, actually, it's mainly for metastatic disease, and those metastases should demonstrate a very heavy uptake of gallium-68 or demonstrate pathologically high level of somatostatin type 2 receptor before having a treatment. So those are mainly the indication. About the contraindication, maybe actually because it's more into clinical research, I think that somebody that having a hematological or biochemistry problems or kidney renal insufficiency may be contraindication for that.
So you do screen people, apart from just uptake, you screen people if their general medical condition and
Of
variety
course,
of lab work. Yeah?
we treat the patient, the whole patient.
Okay.
Could I just add to that? The renal function is critical because the material that doesn't bind to the tumors by locking into their somatostatin receptors is excreted by the kidney. So if the patient has renal insufficiency, it's contraindicated. And there also has to be adequate hematologic function. There has to be adequate levels of the white blood cell count and adequate levels of the platelet count.
And for that purpose, Jean-Mathieu and I are proposing actually to check at the biodistribution and the dosimetry of the tracer to be sure that we will give the right amount of radioactivity without destroying the kidneys. So that will be part also of the research topics.
Two last questions. Dr. Coles, you mentioned cholelithiasis as one of the side effects of somatostatin. What is it, and what is the risk?
Okay. Cholelithiasis is the fancy medical term for gallstones. And it occurs in 50% of patients on chronic octreotide therapy. So when the patient first presents, if the primary tumor in the small intestine hasn't been resected and the patient's in good physical condition, we will seriously consider surgical consultation to resect the primary tumor and at that same time do prophylactic removal of the gallbladder. Reason for considering it, let me give you an example. Sometimes women with breast cancer present with liver and bony metastases and a tumor in the breast, and we'll go right to systemic therapy and not bother to resect the primary tumor because the chemotherapy or hormone therapy will affect the tumor in the breast as well. In carcinoid patients, this is a personal bias, but increasingly other major centers are adopting it. We have a low threshold for resecting the primary tumor, even in the face of liver metastases, because 75% of my patients with liver metastases are still going to be alive 5 years from the time I see them. 75%. And in that time period, if the primary tumor is still in place, it's going to stimulate formation of all this scar tissue that wraps itself around the blood vessels, contracts and retracts the intestine, and it can lead to a surgical situation where the surgeon just goes, wow, I can't do anything about this. So we have a low threshold for getting it out early because patients are going to live so long, and at the same time remove the gallbladder.
The surgeons at the side table are vigorously nodding their heads. Last question, it's a clinical question for Dr. Coles, and this is one I struggle with as well, but this one I can read. So for a person who had a tumor removed from the stomach and a few small tumors in the liver that have been stable over the last 42 months on somatostatin LAR, 20 milligrams, how about a drug holiday? How long do we keep these people on with very low volume, stable disease?
If a patient asks me that question, I would tell them you will become an experiment of one, because I don't stop samizdatin if it's working, as it is in this hypothetical case. Now, if you want to take the risk and become an experiment of one, it's your prerogative, but I do not recommend it.
Okay. So that concludes the question and answer period. I just want to thank our speakers this morning for what I think were a real series of just superb talks. Thank you very much. And I hope for everybody here it illustrates how important this whole concept of multidisciplinary communication and teamwork is for all of our patients in all the situations you guys face. So enjoy lunch. Jim, do you have some?
And certainly our heartfelt agreement, first class. Thank you very, very much. Very good information.